but also on the long-term outcome, and see what it does, what the promise is of this device in terms of restoring vessel physiology, pulsatility, and better clinical outcomes. So with that, I would like to invite Dr. Capodanno to talk about the modern PCI strategies. Thank you.
Okay, thanks so much. So I was asked to somehow frame and set the stage for this session where we will discuss many aspects related to the future of PCI, but my task is to talk about the present time and what is so-called modern PCI in 2026. So, first of all, the good news is that PCI is safer than ever in 2026 after 15 years from its introduction, but still there are outcomes that can be improved. And I selected this meta-analysis, which is one of the many, but I think it's particularly meaningful because this was the companion document to a document from the EuroPCR and the ESC that was asked by the European Commission and the task force for the regulations related to stent approval. So basically, they did this meta-analysis of 158 randomized clinical trial of drug-eluting stents at the time in order to come with the pooled rates of events that are representatives of what can be achieved or was achieved in 2015, 10 years ago. So mortality is 1.9 in the pool rates, TLR is 2.9, myocardial infarction is 2.9, and stent thrombosis is 0.5. The follow-up was 9 to 12 months. So you may say that these are excellent results already, but it's not zero, obviously. And then when you look at the very latest randomized clinical trial that is available on PubMed, this is AbilityDM that was published this year, 2026. I remind you that this was a study of 3,032 diabetic patients, and they were randomized to two stents, the Abluminus and the Xience. So look at the curve for the Xience, which was the winner of this comparison. 6.2% of events at 1 year, and you see that there is a steady progression of events, and of course you can imagine that this will increase at 2, 3, 4, 5 years. So of course we still have a problem because these are outcomes that can be improved also when we look at results that are very contemporary. So how can we improve these outcomes? One way to do it is, of course, to direct our strategies to the right lesions, and physiology is one way to do it, because physiology is the way we try to identify which lesions will be beneficial if we treat them. And in that respect, let's give a look to FAME3, which is particularly representative. CABG with PCI have CABG as a winner, and this is no exception in a way because at 1 year PCI was not non-inferior as compared with CABG, but the outcomes of 5 years show that at least there is no significant difference between the two numerically, although you see that MI and revascularization is still better with CABG. This is not surprising, but perhaps one of the messages that if we want to narrow this gap, physiology is one way to go, because this is perhaps the trial where the two curves are closer. But of course, this is FFR, but there are many other aspects of physiology 2.0, IFR, pullback mapping, angiography-derived physiology, virtual PCI. And this is an example that comes from recent literature, vessel FFR. So this is a computational approach, and this was investigated in one trial that was presented at the ACC, FAST-3, where 2,235 patients with intermediate coronary artery stenosis were randomized to this kind of wireless system versus the wire-based FFR, the traditional one. And you see that they ended up with the same rate, 7.5%. Non-inferiority was met for the simpler strategy without a wire. And also there is another approach, which is the FFR angio, where the all-rise trial also at ACC was presented. In this case, it's more or less the same number of patients, almost 2,000, again, intermediate lesions. They were randomized to FFR angio versus a pressure wire system. And again, this was absolutely similar. So this is probably one way to simplify the physiology assessment and also not using a wire. The other way we can somehow bend the curve of events is to use imaging, of course, for planning, for precision, for verification. And this is perhaps a glimpse into the future of CT-guided PCI. This is a left main case where you can see that thanks to CT, we get information regarding FFRCT, virtual planning, myocardial mass. So this is perhaps something that we don't have available in all the institutions. And we rely more on IVUS and OCT, which have, of course, some benefits. Shortcomings should not be seen as mutually exclusive, but as complementary, of course, depending on what we want to see. However, at ACC, we have seen the results of this trial, which is called IVUS CHIP. These were patients undergoing complex PCI. They were randomized to IVUS-guided PCI versus angiography-guided PCI. And this is a kind of outlier in the landscape of all the trials of imaging that were successful so far, because the primary endpoint was not met, and IVUS was not better than angiography in this case. There may be many reasons for that, but in the same conference, we have seen also another trial that goes in the opposite direction compared with what we expect, optimal, 806 patients with unprotected left main coronary artery disease, randomized to IVUS-guided PCI or angiography-guided PCI. So here we have two possibilities. Or the angiography-guided PCI was too good because the operators were able to react to what they were seeing, or maybe they didn't do what I was mandated to do. This is another interpretation, that there was no much difference between the pre and post IVUS because they simply did not react to what the IVUS mandated to do. So we will see further analysis for sure, but the overall bulk of evidence is still in favor of imaging in the meta-analysis, also including these two trials. Another point which is very contemporary is to good lesion preparation because calcium predicts the underexpansion, and here we have several options: rotational atherectomy, orbital atherectomy, excimer laser coronary atherectomy, intravascular lithotripsy, scoring, and cutting balloons. And of course, this would demand separate talks for each of these subsets: bifurcation lesions, left main, chronic total occlusions, diffuse disease, and long lesions. These are complex anatomies, and they, of course, ask for dedicated strategies. If we do not follow precise techniques for these lesions, of course, we end up with troubles. And the final point I want to make is, of course, regarding the permanent devices that we leave in the coronaries of the patients. So what we are learning, of course, is that we need to be a bit conservative because some of the events that we see in these patients still are related to the caging of the vessel and the metal that we leave. So we should leave not nothing but less behind, and perhaps go for hybrid strategies. And we need to protect more our patients also with the pharmacology. We have several leave less behind strategies, bioresorbable scaffolds, which are not ready for the prime time. Maybe there will be a kind of a comeback with the second or third generation. We have drug-coated balloons where the RECAGE 3 trial was not positive for this technology. We are waiting for the publication of the solution de novo. And of course, again, there are different interpretations regarding whether this has to be considered an entirely positive trial or there are caveats. We have bioadapters, and of course, in this session, we will hear more about that. And of course, we have an avalanche of drugs that try to tackle prevention more than, of course, treatment and treatment as well. So when we look at the difference between the devices that we have for PCI, we see that some of them are permanent. That's the case for the bioadapter and the drug-eluting stent, as opposed to DCB and BRS. In terms of caging, however, the only technology that caged the vessel is the drug-eluting stent. In terms of scaffolding properties, you see that this is lasting for the DES, it's transient for the BRS, and it's adaptive for the bioadapter. The vasomotion has been demonstrated for the bioadapter, is likely for the DCB, and is not demonstrated for the DES and the BRS. And in terms of accrual or long-term device-related events, there are ongoing investigations for the bioadapter, and we see that there is an increase in late events with the other technologies. The bioadapter is made of 3 helicoidal strands that disconnect at one point in time, thanks to these connectors that are biodegradable. And this is something that allows the vessel to restore properties such as the cyclic pulsatility, but also the rotational motion. There is also some evidence that there is a better response to pharmacological agents, at least in soft plaques, and we can also maintain the ability of positive arterial remodeling thanks to these properties. So the final slide is just to invite you to attend this session, which is in collaboration with Eurointervention and the Lancet. So we will discuss the work of the Lancet Commission on rethinking coronary artery disease, where the key points is really shifting our mind and the paradigm from ischemia to atheroma, because if we tackle atheroma as an anatomic entity more than the functional consequence downstream, we are able to prevent this disease, especially with all the drugs and pharmacology that now are available, more than to treat when perhaps it's too late. So in conclusion, how do we further optimize with modern PCI the 5 to 7% of residual coronary events in 2026? Summarizing, I think there are 5 strategies that we have to concentrate on. First of all, to target the right lesion with physiology, to image in order to verify, plan, and optimize, to prepare the lesion properly, to respect the anatomy with a proper strategy, but of course, think beyond drug-eluting stents, because we need to have improvement also in that field. Thank you.
Thank you, Dr. Capodanno. That was really a terrific overview of modern PCI strategies. Very interesting to see that you are now adding a column to what we currently have. So very exciting. And now we need to move on. I would like to invite Dr. Werner to give us a deep dive in the 2 randomized clinical trials that we have on the bioadapter. And he will share the latest evidence and the mechanism of adaptive angioplasty. Please, Nikos.
Yes, thank you very much for the kind introduction. I will show you today the bioadapter clinical evidence, give you an overview about that. But let me start first with the clinical problem. I mean, we have seen it in the recent talk, but when you look at stent-related adverse events post 1 year, you can see that there is a constant increase in cardiovascular events. And in this kind, you can see that there's a significant increase in target lesion failure. And this occurs every day, every year, which follows. And the same holds also true for drug-coated balloon, by the way. You can see that on the right side. So one solution may be the bioadapter implant. And you can see that here it consists of 3 strands. And these 3 strands are connected by each other with a bioresorbable polymer. And after 6 months, this polymer resolves and let the vessel allow to restore its vessel function. And this may be something which is completely different to previous strategies in stenting, and allows the vessel to become more like in its initial form. And the pulsatility, the compliance, and the adaptive remodeling may improve cardiovascular outcomes. And for the bioadapter, we have a very robust clinical program. You can see there are lots of cohort studies, case reports, and reviews already published. But there are 2 major randomized controlled clinical trials. One is the bioadapter randomized controlled trial, 445 patients, 1-to-1, compared to the Resolute Onyx stent. The 2-year follow-up has already been published in JACC Intervention back in 2025. And we have the Infinity Sweetheart study, 2,400 patients, again a 1-to-1 comparison to a drug-eluting stent, powered for non-inferiority, but also powered for superiority in a much larger number of patients. We wait for the 5-year clinical follow-up. The 1-year clinical follow-up has already been published back in 2024 in The Lancet. And I will show you an update on these both studies. First, the BioAdapter randomized controlled trial and the 4-year outcome. As you can see, 50% of the 445 patients were enrolled in Germany, Belgium, and New Zealand, and 50% in Japan. Randomization 1-to-1 of the BioAdapter to a Resolute Onyx DES. The 1-year primary endpoint is target lesion failure. Here, as I stated, I will present the 4-year clinical follow-up, also presented today in the late-breaking session. Just to remember you, patient baseline characteristics shown here, a significant number of patients with hypertension, dyslipidemia, and roughly 30% of diabetics. We have interesting anatomical characteristics, 50% LAD treatment, but we also have osteal lesions, bifurcation lesions, and as you can see, moderate to severe calcifications and tortuosity in roughly 20% of our cases. So this is the outcomes at 4-year follow-up, and you can see a sustained significant reduction in target lesion failure with the BioAdapter compared to a contemporary drug-eluting stent. You can see there's a significant difference between the DES and the BioAdapter with a significant p-value at 48 months for the total cohort. Going more into detail, and I think this is a very impressive slide, you can see that target lesion failure was reduced using the DynamX in the population compared to a contemporary drug-eluting stent by relative risk reduction of 66%. And also there was a significant difference between drug-eluting stent and the DynamX BioAdapter of 88% relative risk reduction in terms of cardiovascular death, which is something which is really very, very impressive to see. And also when you look at target vessel myocardial infarction and clinically driven target lesion revascularization, you see a numerical benefit for the DynamX BioAdapter. So the LAD is, as we know, a very important vessel. And here you can see a very interesting dual source photon CT counting, where you can see the high torsional and rotational forces of the LAD. And we know this is a difficult vessel because we have a high degree of curvature, we have a lot of branches, and it's mechanically difficult and challenging to receive optimal stent results. And especially in these vessels, and this is normally the most important vessel, standing restricts the vessel motion, and this elevates biomechanical forces, maybe linked to the progression of cardiovascular disease. And when we look at the subgroup of patients with LAD intervention, you can see again the substantial benefit with the BioAdapter compared to the DES throughout 4 years. So coming from the BioAdapter study to the Infinity Sweetheart randomized controlled trial, 24-month follow-up, completion of 100%, 2,400 patients out of to evaluate a potential superiority of a clinical benefit after 6 months on reducing non-plateauing event rates compared to drug-eluting stents. And there was also a predefined subgroup looking at the patients with acute coronary syndrome and complex lesion. So here are the baseline lesion characteristics, and you can easily see that these patients were more complex than in the BioAdapter randomized controlled trial. You see more patients in lesion classification B2C, more bifurcation, calcified lesion. There were like a significant number of patients where 2 stents or more were used. And so it's a typical all-comers population. And here you can see the superiority endpoint, target lesion failure from 6 months to 2 years. So independent study from the bioadapter study, much more patient. And again, you can see a significant reduction in target lesion failure with a sustained treatment benefit after 6 months. And you can see it's a much more plateaued phase after the 6 months compared to the drug-eluting stents. And again, when you look at the different components, which are shown here, you can see relative risk reduction of 48% in target lesion failure when patients were treated with the DynamX bioadapter. And again, numerical advantages for the bioadapter compared to the contemporary drug-eluting stents, with no difference in definite or probable stent thrombosis over the observation time point. So as I told you, there was a subgroup of acute coronary syndrome. This is shown here. And again, this subgroup also showed superiority in terms of target lesion failure when patients were treated with a dynamic bioadapter. So I think this is very convincing data. And we also looked at more in depth into different contemporary and modern PCI strategies. Here you can see the overall population, the population who received an intravascular imaging or physiology-guided PCI, as shown in the previous talk, and the patient with an angiographic-guided PCI. And again, you can see that the differences between groups were constant throughout groups, so there was no significant treatment effect in terms of intravascular imaging or physiology. So in conclusion, I think we can say that the bioadapter is a new class of technology with distinct functional mechanisms. Both trials has consistently demonstrated superiority in terms of outcomes with the dynamic bioadapter versus contemporary drug-eluting stents. We saw sustained significant reduction in target lesion failure, including an ACS population, reduction in cardiac death, and a marked benefit in the important LAD lesions. So results of both trials show that restoring vessel function with a bioadapter and these 3 helicals worn into each other have a significant translates in significant clinical benefits and seem to be superior compared to metallic drug-eluting stents. Thank you very much.
Thank you, Dr. Werner. Now we have Dr. Kuzuma, who will discuss the results here. So we have a bit of a different format, and each of the cases also that will follow will be discussed. So Ken, please,
okay.
How is it going to translate?
Okay, so thank you very much for having me in such a wonderful session. So I'd like to raise some questions to the audience. So Dr. Werner demonstrated, and 2 randomized trials demonstrated superiority in terms of the target lesion failure. And bioadapter has consistently demonstrated better outcome, especially in the late phase, regardless of the event type. Not only target lesion revascularization, but also target lesion-related myocardial infarction and cardiac death. And especially in Japanese cohort, we are a major enroller of bioadapter RCT in Japan. And most of the Japanese patients were treated with intracoronary imaging guidance. So with the intracoronary image guidance, we can reduce the acute event and also the midterm clinical events. But we cannot omit late event with this imaging guide PCI. So bioadapter will increase the benefit at the later phase. So my question is, there was no interaction in any subgroup of analysis into this RCT. So all patients will have benefit from this bioadapter. But I don't know the price of the bioadapter yet, because in Japan, bioadapter is not reimbursed yet. But probably considering the superiority of this feature of bioadapter, this device may be very expensive. So we have to consider which patient have bioadapter, and the others should conventional drug editing stents. So probably judging from the mechanism of compression in LAD will have a much better outcome. And also considering the patient remaining life. If the patient has 30 years remaining life, so patient will have coronary event related to more than 30% related to the target lesion. So such patient will have a much more benefit from this bioadapter. So from now on, we will see 3 case presentations. So please consider which indication will be the best for bioadapter. Thank you.
I don't think we can discuss prices here for the bioadapter, but any questions from the audience? Having seen the data here, I think what is very striking to me is not only the reduction in TLF, but also, and I would like to have David's impression here, it's the first time, as far as I know, that we've seen differences and reduction in cardiovascular death, even in such a small population at 4 years. Do you have any, would you like to have a comment here?
Well, first of all, the shape of the Kaplan-Meier curves is interesting because at the time of the bioresorbable scaffold in 2013, 2014, you remember that there were these slides that were promising something like that. So flattening of the curve for the treatment investigational strategy, the BRS, and then accrual of events for the drug-eluting stent. And we have not seen that, obviously. So it's very nice to see that this is now realized with the novel technology. And it's, I would say, more than promising, because when I saw the bioadapter RCT, I said, okay, interesting, but let's see now the burden of proof is with this device in the larger trial, and this was realized once again. It seems that the benefit is really continuing, but I would say upfront. In the first 12 months, there is something really magical there. And yes, reduction in cardiovascular mortality, it's a secondary endpoint, so obviously it's not powered for that, but it brings to our mind that stent thrombosis can be involved in a way. So if this is really a technology that somehow protects from this complication, I understand also why the driver of this primary endpoint is cardiovascular mortality. This has to be confirmed, but obviously very promising.
You think this could also be driven by, there's a significant reduction in LAD outcome, the lesions in the LAD. So, but you know, we know it's the widowmaker. Do you think that there's an influence driven in the LAD proportion to cardiovascular death reduction?
Seeing is believing. No? So when we see these CT images with the torsion, etc., it's speaking more than 1,000 words that this is area where, of course, the torsion can really damage the stent. So it makes sense, and it's not surprising that this is the subgroup that immediately stand out as a very positive. So I think if we have to select one lesion where this is a good candidate, LAD perhaps would be, the proximal LAD would be one.
All right, so let's move on. Seeing is believing, like you said. We'll go to the first case in multivessel disease. I would like to invite Dr. Gana to present the case, and the discussion will be led by Davide.
Hi, good afternoon, everyone. I'm Dr. Ganapati from IJN, Malaysia. Okay, I don't have any potential conflict of interest to report. So I go direct to the case. So we have a 54-year-old male, BMI of 26, and he had a recent non-STEMI, NYHA class 2, CCS class 2. Echo shows a EF of 52 with no regional wall motion. Social history is married with 3 children, policemen. He has underlying hypertension and hyperlipidemia. We went directly to the angiogram. So the left circumflex is fairly okay, and if you see the left LAD, the left anterior descending artery, the proximal segment, there is a severe disease followed by a myocardial bridging at the mid segment. So this is the areocranial and the iliocranial view. So we did an OCT run. OCT shows a fibrofatty plaque. Mid-LAD sizing is 3.0 just before the bridging, below the diagonal, and 4.0 at the ostium. Strategy is we decided to pre-dilate just below the diagonal towards proximal LAD and to deploy a bioadapter scaffold. So we did a scoring with a 3.015 sequential, and then this is a shot after pre-dilation. There is no dissection, is good. So we can proceed with the stenting. So we decided to stent just slightly below the diagonal. However, when we deploy, the stent went into the myocardial bridging area. So when you stent a myocardial bridging, so what is your concern is mainly is compression, or does it result in a dissection, or in the worst case scenario is an acute closure. But this is the shot after after the scaffold deployment. So far so good. There's no dissection, there's no acute closure. We decided to post-dilate from the diagonal onwards with the NC3515. And this is the final shot. And this is the OCT run. However, saying that when we stent a myocardial bridging, you always have a concern in the later part. And long-term concerns is mechanical fatigue of the scaffold of the stent fracture, recoil, restenosis, or thrombosis. So what happened is 1 year after, almost 1 year after, a bit shy of 1 year, 11 months after, he went to another center because of another episode of chest pain. So it's another colleague from our hospital previously, so we know him. This is the restudy. The restudy shows the stent is patent. The right side, I'm not sharing here, but right side is also normal. So we always fear of deploying stents in myocardial bridging, right? So this unexpected experience actually challenged our traditional belief. So far, it looks good after 1 year, and the bridging area is still pulsatile, as you can see there. So can bioadapter be used only in simple lesions, soft plaque, or short lesions? Can it be applied in a complex lesions? So what actually matters here is the lesion preparation does matter than the lesion complexity. So image guiding is very important. So that is the most important thing. I'm sharing you a second case as a CT of RCA for the mid segment. We managed to cross it, and we decided not to cage. We made sure it is true lumen all the way. So we treated the distal part with a paclitaxel eluting balloon, and mid segment with a bioadapter 3538, and the proximal segment is 3532, and post dilate with an NC35, all with IVUS guiding. So these are the final results. Well expanded, IVUS is good. So I show you a third case. Even in a calcified lesion, proximal to mid LAD, there's a severe calcification. We couldn't even deliver the balloon. After sequential lapid crawling, we managed to deliver a scoring balloon. However, the scoring balloon dock bone there. It couldn't open. So we have to rota the lesion. After rota, we managed to deploy the bioadapter scaffold, and the results is excellent. So this is what being shared by everyone before. So this is novel trial. Novel trial used regular stents. Imagine regular novel trial being done with a bioadapter scaffold. This is just an imagination. So this is an AI-based conceptual projection. This is not evidence. We give data to the AI, the first year, second year, and third year data, and give the novel trial and ask what is the possible outcome with a bioadapter, and this is the results. It's very beautiful, right? So novel trial, if it is done with bioadapter, the result might be totally different. So saying that, bioadapter might be the future. Thank you.
So congratulations and thank you for the two cases. The second one I would say is more regular. So this is what you would expect a good subset to tackle with the bioadapter, long lesions, avoiding the long chain. The first one is more provocative, so I would like to ask you, so you did OCT exactly to avoid landing in the bridge, no?
Exactly. Possible.
Definitely, and so the big discoveries comes by chance sometimes, no?
Exactly.
And you have seen that even if you put this technology, a drug-eluting stent, in the bridge, which is the first thing we teach fellows not to do, in this case, probably the disconnection helped in that regard. So it's a very interesting finding. Do you think this is something that should be also tested in a proper manner or not?
Okay, we always have lesions somewhere near the myocardial bridging or sometimes in the myocardial bridging itself. Sometimes what we do is we try to avoid the myocardial bridging side. We might sometimes just do a pure ballooning only, but sometimes it may result in dissection. In case of dissection, I think the bailout could be this. This could be the answer for the bailout. That's what I'm thinking.
Yeah, I want to ask also an opinion of the panel. So the message is not you should stent the bridges, but maybe this technology is forgiving in this situation.
Yeah, maybe in some cases that, of course, you want to avoid stenting bridges, but maybe in some cases that we have lesion and bridging, bioadapter can be a solution, a new solution. But I think it should be tested.
Yeah. This was unexpected. That's the result.
Yeah, maybe it's registered. So let's say this is room not for randomized big trials, but for those who have similar experiences retrospectively to collect. I think it's important to put the data all together and see whether there is a good follow-up. Regarding the second case, maybe we can also discuss. So this is a situation where you have a long chain of stents.
Correct, exactly. So this is a total occlusion of the RCA. So if you want to do it might end up with a metal jacket, a complete metal jacket, if you put a stent from the distal RCA up to the ostium. So we avoided by doing a drug-coated balloon at the distal segment, and the mid segment was a bioadapter scaffold, and the proximal segment is another bioadapter scaffold. The result is very good.
And you remember that at the time of the scaffold, the story, we were said that the pulsatility, vasomotion, these are very important outcomes for angina relief, etc. Do you believe this is true, or it's just marketing?
So far, we have been doing this for the past 2.5 years in our institute. Zero restudy. They don't come back with another episode of acute coronary syndrome or any angina. So even the patient that had a myocardial bridging, he went to another hospital because of atypical chest pain, and the hospital decided to do the angiogram. However, the angiogram turned out to be normal. So we managed to get the angiogram to share with you guys today. So far, we don't see any critical results. Excellent.
I think it's very interesting indication, CTO for bioadapter, because we are using in CTO more and more DCB. Just one mechanism is down-regulated vessel. When we are giving antegrade flow, the vessel is growing in some weeks. So maybe we should check bioadapter if there's a good mechanism for CTO as well.
There is a study which was shared. Last year, I think. The vessel grows even with bioadapter because of the ring shape is gone, just strands there. So it still grows together with the vessel. That's the study shows. Even in diastolic, there's a 7%, I can't remember the study, there's a 7% increase in a normal vessel itself. Even it grows approximately 19 to 20%, if I'm not mistaken. I forget the name of the trial. Yeah.
Thank you, Dr. Gana. I think
thank you.
For the interest of time, we need to move on, and thank you again. I'm sure we can continue the discussions, but I would like to ask Dr. Mangieri to share his case, and this is going to be in bifurcations. And the discussion will be led by Nikos.
So thank you so much for the introduction. The bifurcation that we did in our institution. Essentially, we go straight to the case. We have a 70-year-old male with a common cardiological risk factor. He came for a stable angina. He underwent basically a CT scan that showed a severe ostial RCA stenosis with a proximal LAD stenosis, which appeared to be severe. So the patient was brought to our cath lab. You see that on the RCA we have, I would say, moderate stenosis at the ostium of the RCA, which was left behind. And essentially, if you see the caudal and the cranial projection, you can appreciate the presence of a long diffuse critical stenosis of the LAD involving also the first diagonal, which appears to be quite big. So according to our internal study, which was the DynamX, who aimed to study the complex lesion in which we studied essentially patient at the baseline and at 9 months follow-up, we were able to see with this small study very good outcomes in patients treated with such complex lesion. So these patients was enrolled in this study, and our strategy was to first prepare the LAD, and for do that we utilized a common non-compliant balloon because the lesion appeared to be essentially fibro-fatty and not with a high burden of calcification. You see that the 3 non-compliant balloon was inflated without any trouble, and then we proceeded also pre-dilating the diagonal with a semi-compliant balloon. We also went with a scoring balloon just to optimize the results because of a high amount of fibrosis that we observed. And so we obtained a good lesion preparation of both branches, and then we proceeded with implantation of a bioadapter 30 by 28 post-dilated with a 3.5 non-compliant balloon at high pressure. And as our practice, we usually do, and we love to do, this mixed bifurcation strategy, so implanting the decimal and not caging the diagonal. So we delivered a paclitaxel coated balloon. So the procedure was good. The final results, as you can appreciate by the OCT run, was, I will say, excellent, with a very symmetrical stent expansion. You see the pullback coming on all the LAD. You see also patency of the side branches, which is very important when you treat the LAD, just to avoid the peri-procedural myocardial infarction. So the patient came for the study at 9 months follow-up, and this patient was considered for the sub-analysis that we were able to make. Essentially, we decided to play 2 runs of OCT, one after acetylcholine and one after nitrates, just to observe wherever we were able to find some difference in terms of vasomotion inside of the stent. You see that the angio looks almost perfect, with also good results in terms of late lumen enlargement on the diagonal. You can appreciate here the 2 runs of OCT and also the 2 angio. You see that essentially with the nitrates we were able to observe an overexpansion of the stent, so with a good response to these nitrates administered intracoronary, but at the same time, so we have a vasoconstriction of the stent when we administer acetylcholine. So the vasomotor response was analyzed also in some other subjects that were included in our study, and you can appreciate how consistent are the results among this small population. Of course, the numbers are so small to draw definite conclusion, but we were very confident that after the analysis will be definitely positive and able to show a sustained vasomotor reaction in this patient at 9 months follow-up. So I will not go longer, but I will say that essentially this new technology will allow us to treat more complex lesions, as demonstrated by our studies. And of course, we will be able also to see a vasomotor reaction of these patients that can potentially benefit from this vasoreactive motion that is not observed with the normal caging with the standard DS platforms. Thank you for the attention.
So thank you, Antonio, for this excellent case. Are there questions from the audience, first of all? Yes.
Sorry, I am from Brazil. My name is Costantini. I would like to know for the panel, after to see the number from Japan, if the IBUS or OCT is not important for this device, because I saw very nice number. For the first presentation, 2.8 filer lesion treat versus 1.9 and 48 months. I don't know. I would like to know for the panel, what do you think about this? Because in our institution in Brazil, we use 100% intravascular ultrasound, and our number is very different. And when we almost published now, almost we will publish the next month, 10 years absorb stent in our pilot 100 patients. And the number after 10 years are fantastic. And all the patients using 100% before, during, and after procedure, IBUS or OCT.
Thank you, Dr. Constantini. I think Dr. Werner can address this question. He did a deep dive on the Infinity Sweetheart, where we have a sub-study looking at the differences with intravascular imaging / physiology. And as you know, as also alluded by Dr. Capodanno, if you do imaging or not, angio-based or IVUS imaging, basically you have a better outcome. But I think it's very interesting data that we derive from Infinity Sweetheart. So, Nikos?
So I think every time you do imaging or physiology in the subgroup analysis, the outcomes was better, irrespectively whether we're using DES or the bioadapter. But in general, you're completely right. When you look at the very low numbers of target lesion failure in the bioadapter, this is something completely new and something we haven't seen before. But this is irrespectively and even better when you go with intravascular imaging. There's also another question from the audience about the technical aspect of bifurcation treatment. So can you do DK crush? Can you do culotte or tap standing? Is there any restrictions, or can you do everything you want?
Yeah, thank you. I think this is a very interesting question. Technically, I think it's possible, but in our study, we did not use the two-stent strategy, I tell you the truth. Essentially, we included bifurcation, but were all provisional stentings in which we were very encouraged, like also to perform, kissing balloon. So we had a sort of distortion of the adapters, but we did not observe any issue at the follow-up, and all the follow-up were OCT guided. So I think was a very reliable answer that I give to you.
Okay, thank you, Dr. Antonio. Thank you for your case. And I would like to ask Dr. Sobieszek to present the last case. This will be discussed by Dr. Kuzuma.
So good afternoon. Thank you for the invitation. I'd like to present a calcified case, calcified lesion treated with bioadapter. So this is a clinical representation of the patient. It's 82 years old male with CCS class 3 with multivessel disease with after PCI of circumflex with quite good ejection fraction. This is our target. Mid RCA calcified lesion. So we use guide extension to have better visualization and to cross the lesion, and still it's undilatable lesion. So we use, you can appreciate on stent boost the calcifications, and we use the new lithotripsy method lytics, and you can appreciate the good expansion of lytics. And then bioadapter with post-dilatation. However, edge dissection and we have a problem. Whoa. Too fast. Okay, and we have good results. So we have in the same vessel bioadapter and dry clotting stent in the same patient. And this is control after 8 months. It's looking quite okay in angio. But in OCT, you can see that in dry clotting stent, we have instant restenosis. And in bioadapter, there's no restenosis, and there's a good expansion and uncaged vessel. So, of course, the PCI of restenosis with DCB with good result, then control after another 6 months with good result. and dry clotting stent. And of course, we can appreciate direct comparison and advantages of bioadapter that we discussed, of course, the lesion before bioadapter, but I think before every dry clotting stent or DCB should be well prepared. Thank you very much.
Thank you very much for a very interesting case. So severe calcified lesion with long lesion may be a remaining issue for bioadapter.
Yep.
Do you have many experience on this type of subsets?
You
Very
mean
severe calcified
with
lesion?
complex lesions, yes.
Yeah.
So I think we are in the era that we will try more and more complex lesions with bioadapters. So I tried CTO and calcified lesions. Of course, there is a discussion. What about vasomotoric function restoring in calcified lesions? But yeah, we know that we have some segments of vessel that are more calcified and less calcified. So I think bioadapter and complex lesion will be in the future main solution as well.
Okay, thank you. So are there any comments or questions from the audience? Okay, so probably,
As we know, the left man have more elastic tissues than compared to the LAD and this. So this bioadapter have a good radial strength and this expansion. So in near future, they will try to select the patient, especially in left man, compared to other stents which have less radial strength and less thickness and more recoil.
thank you. So aortic austere lesion may be a good candidate for the bioadapter.
I think there's a nice point of discussion as well. Should we limit it bioadapter because it's not reimbursed to LAD? Because, of course, we know that LAD properties, vasomotoric properties are completely different. And this is, I think, the one reason we have a good effect in LAD with bioadapter. Another is that it's big area of ischemia. But I don't know about the panel, question to panel, if you are using in another vessels bioadapter as well, especially in tortuous vessels.
I think it's really important to state that there has been no differences in different lesion or different vessels in the studies presented so far. So we have the subgroup analysis of LAD, but the bioadapter also works in RCA and CIRC, so there's no difference. And of course, we only discussed the lesions we discussed recently, but we have only very limited data on left main and all other complex lesions. So I think we need to wait for the data before we go too wild and use it everywhere. I think we need careful intravascular imaging in order to decide whether the patient is a candidate or not. But as far as we know at the moment, there are no limitations from the studies that we see that there's lesions or patients which are not suitable for the bioadapter.
Completely agree.
Okay, so the last question, please.
Hello. If you had to treat a very, very long lesion and must use two bioadapter, what happened with this overlap segment after 6 months?
So do you have any experience of the overlap segment?
Yeah, on our experience, essentially, we did not observe any big difference in terms of like OCT volume hyperplasia that you find like between the connection of two stents. You have, of course, more struts, more metal in this part, but essentially we did not observe any significant like problem at the overlapping edges of the two bioadapters.
Thank you.
Okay.
In the, I can just give a little comment here. In the very early mechanistic trial, we had patients where we had overlap of two bioadapters, and there basically was a very good outcome even on OCT. So even there you see differences in, you have cyclic pulsatility, systole, diastole. So no problem with overlap whatsoever. So just want to have some closing remarks and takeaways here. I think we've all heard and seen that it's a very promising device. It actually lives up to the promises. We have seen very nice examples of restoration of physiology, cyclic pulsatility in the cases that were presented. I think I'm still very much intrigued by the fact that when you administer acetylcholine, you get a vasoconstriction within the stented segment, and if you give nitrates, you actually have a dilation of the stented segment. So again, this is something that I have never seen before, and which is very promising, and this contributes also to the better clinical outcomes. And this is also translated in the trials that we have shared with you, the bioadapter randomized controlled trial, in a very global population, Japan and Europe, as well in the Infinity Sweetheart, where you have very convincing data, clinical, but also angiographically, and in terms of IVUS and imaging and physiology. So very promising data, and I would like to invite you to attend the DynamX BioRestore Real World Registry. It's a registry, so it's not the data are not embarked, but the data, it's a study of 5,000 patients approximately, and about 700 patients roughly will be presented on Thursday in the morning. With that, I would like to conclude the session. I hope you enjoyed the symposium. I would like to thank the panel, Elixir, and of course you all for attending. Thank you so much.
Reviewing our manuscript, Nature Trial, and the cutting. So we will have follow-up data